I have no financial disclosure. Now we're all aware that corneal cross-linking increases the biomechanical rigidity of the cornea, but alongside it can also cause a keratometric flattening. In keratoconic eyes, they have shown that if you have smaller diameter cone localized treatments, the flattening that is induced is much more as compared to the standard broad beam. So what if this was extrapolated to normal non-ectatic eyes, wherein we produced a central flattening in order to induce a myopic correction? This forms the basis of photorefractive intrastromal cross-linking or pixel. The results thus far have been promising, wherein they have seen that the change in MRSE as well as the keratometric flattening was greater in the epithelium of protocol as compared to the transepithelial approach. But the epi of protocol has limitations, that is postoperative patient discomfort and the risk of infections and haze. Now, one of the reasons why this might be happening is because the amount of oxygen reaching the stroma in the epi on protocol is limited, thereby limiting its efficacy. So our question was, would supplementing oxygen to this epi on protocol give you better results for the treatment of low myopia? This was studied in a prospective interventional case series where patients were enrolled from March till December 2017 and followed up for a minimum period of 1 year. We obtained ethics clearance, committee clearance and a written informed consent. The inclusion criteria were the same as traditional LASIK. The only difference was we were targeting low myopias of up to 2 diopters with negligible cylinder. Exclusion criteria was similar to keratoconus for cross-linking. The only difference was that patients with squint or nystagmus or other pathologies which may preclude a steady fixation were excluded. So we used the transepithelial approach, which has riboflavin along with BAC for a 10-minute soak. This was then followed by customized UVA irradiation in the central 4 mm zone only. So this is a small video which shows a central 4 mm irradiation of a total of 15 joules per centimeter square in an accelerated pulsed approach. That mask you see is the oxygen supplementation, which had a concentration of more than 95% throughout the UV irradiation. So what were the results that we saw? We had a cohort of 56 patients, but of the ones which followed up through 1 year, we had 50 eyes with a minimum follow-up period of 1 year and a mean age of 22.73. Now you can see the refractive outcomes over 12 months, wherein there is a change in both the MRSE, the sphere and the cylinder, which has significantly reduced from minus 1.61 MRSE to 0.38. Again, the UDVA improved significantly from 0.63 logmar to 0.13 logmar. In terms of the safety and efficacy, more than 92% of the patients had an unaided visual acuity of 20/40 or better at the 1 year follow-up. Similar results were seen in the keratometric changes with progressive flattening. There was a slight regression between the 3 to the 12-month period, but this was not statistically significant. This is an example of the central keratometric flattening, which is seen in the patient who had a correction of 1.25 diopters. This led to a large amount of time without glasses for most of the day, where more than 21 patients did not require glasses for more than 91% of their time. So when you compare it with the earlier protocols, you'll see both the change in the MRSE and the keratometric flattening was greater, even greater than the epi-off protocol. Safety profile, the incidence of haze and its subsequent resolution was similar to cross-linking. None of the eyes lost any lines because of haze. Again, there was no significant endothelial cell count, and you can see a well-demarcated demarcation line only in the central 4 mm zone. One important question that we had was, does corneal biomechanics play a role? As in, do corneas which are weaker earlier cross-link to a greater extent and have a greater change in the MRSE? We found a correlation between the preoperative biomechanics and the change in MRSE, proving that weaker corneas had a greater change post-pixel. So I'd just like to conclude that the epi on pixel is effective in reducing myopic errors. The oxygen supplementation gives you superior results as compared to the earlier protocols, including the epi-off approach, but comes with the additional advantages of reduced patient discomfort, reduced risk of infection and haze. There was no significant adverse effects noted in our cohort, and corneal biomechanics has a significant correlation and can be the future in evolving nomograms in order to decide the amount of fluence required for correction. Thank you.